Hello, thank you for joining today's webinar. This is John Howlett with Kaufman Hall, and here with me is our presenter, Kris Goetz. Kris is the Senior Vice President with Kaufman Hall's Cost Transformation Team, which focuses on helping healthcare organizations achieve sustainable improvements across their entire cost structure, from optimizing labor and supply chain costs to rationalizing their network of services to managing the clinical enterprise and eliminating unwarranted variation in care. Before we get into the presentation, I want to quickly review a few housekeeping items. Whether you're listening through your computer or via the conference line, all attendees will be in listen-only mode for the duration of the webinar. Those participating through the computer have the ability to send questions to us through the questions pane on your attendee interface. Simply type in your question and click send. At the end of the presentation, we will answer as many questions as we have time for. If your question is not addressed during Q&A, we'll be sure to follow up with you afterward. Please note that material related to the issues we'll be covering today, including the presentation and a related article, are accessible within the handouts area of the attendee interface. With that, I'll turn it over to Kris.
Hello, everyone. Thank you very much for joining today. I would like to introduce myself before we get into the materials. As John said, my name is Kris Goetz. I am working in the strategic cost transformation practice at Kaufman Hall. Prior to joining Kaufman Hall, I spent 7 years as the Director of Operations at a large academic medical center here in Chicago, where I was accountable for financial performance and quality outcomes in patient care. Prior to that, I spent 5 years at an organization by the name of Solutions. It is now Truven Analytics, and I have a significant experience in operational benchmarking. My formal training, however, is in clinical psychology. I'm actually a therapist by training, and those types of skills come in very handy these days. So let's get into the materials today. We're going to talk over the next several minutes about best practices in the industry to address cost transformation efforts. And we'll really talk about how these best practices are not equal. Some are weighted heavier than others. We'll identify some barriers and tactics to overcome those barriers. And most importantly, this is a practical application presentation, and if successful, those in the audience will be able to really take 3 or 4 learnings and be able to apply them in very short order. So before we get into those best practices, let's set the kind of the foundation for our observations and why this is such an important topic. The graphic on the screen you'll see is a graphic produced by Moody's last fall, and it indicates that the healthcare industry continues to grow in terms of its expenses. And in 2015, the most recent year data is available, expenses grew at its highest rate in the last 5 years. As many of you know, healthcare expenditures now comprise 14% of the gross domestic product in the United States, and that growth rate is untenable. 14 of every $100 that your family spend is on healthcare. When we look at the big picture, to envision a world where those dollars can be spent on other things, such as education or infrastructure, really makes the platform and the sense of urgency a great one. It is our professional responsibility to begin to transform the way that we spend our healthcare dollars in this country. The thing that is even more concerning is that this growth rate doesn't reflect the growing inflation that our country is likely to see over both the short term and long term. So when factoring in inflation, as the Fed has indicated several times over, will only exacerbate this issue. So now that we have the dire storm clouds looming, we'll get into the best practices. A struggle that we see is the cycle of futility in terms of organizational cost transformation. The majority of the time, our observation is that healthcare systems view cost transformation as a project or as an initiative. rather than cyclical in nature. And oftentimes it's driven as a product du jour because we have a financial emergency. And then we have an intense preparation and an all hands on deck approach to cost transformation that really doesn't last. It's not sustainable. The level of fatigue oftentimes sets in. We're not willing to address some of those politically sensitive or very difficult initiatives that are required. And so we then focus our attention elsewhere. We go on to the next thing, only to have a financial emergency pop up again. And really what we're seeing is that the cost transformation, when it's not part of organizational culture, tends to fizzle out, and we find ourselves going back to the well time and time again, and it is really frustrating from a leadership's perspective. So to avert that cycle of futility, we've identified a handful of best practices, really starting with the foundation of cost transformation in the strategic plan, in the long-range financial plan, really to have a no-holds-barred or everything-on-the-table approach to cost transformation. We'll then talk for a few minutes about translating overall goals into targets and some new or novel ways of using new sources of data to do that. And then really the last 3 bullet points kind of move away from that quantitative or financial approach. And really what we'll do is we'll touch on culture and building a culture of the right skill set, but also a culture of accountability towards long-term success. So the first best practice is really to tie those goals to the integrated strategic financial plan. The reason why we want to lead off with this is because it is the Kaufman Hall point of view that this is foundational, that this is the very first step, that without a strategic plan and a long-range financial plan that supports that, any cost transformation initiatives are likely not to be have a full appreciation of organizational context and are not necessarily sustainable. So what you see here is a long-range financial plan that understands organizational strategy, that is related to the annual budgeting process, the capital structure, and the capital allocation. The strategic plan will likely have capital goals, will have funding goals, and really it's that type of foundation that informs the financial gap or the operational improvement that is required. Once this is established, the communication can be much easier or clearer because it sets forth kind of an aspirational tone to cost transformation if it's toned in strategy and the organization moving towards perhaps a population health or value-based care model. When it's not formed in strategy, you can see on the left-hand side of the slide, we can then set a cost transformation project that is not realistic or goals that might not be achievable. So let's actually share a very specific example of that on the next slide. This is ABC Health System. We've masked the details on this. But this organization has strategic priorities to maintain their current rating, so they need 200 days cash on hand. They want to restructure their debt to get new money. They want to improve stagnating cash flow. And then they have a $500 million regional capital strategy with a new IT platform. View this example like a balloon. You can't push too hard on any one area, lest we will become out of balance. So the long-range financial plan is all about maintaining balance or equilibrium. And the cost transformation effort is rooted in that balance. So let's take it a step further and show an example on the next slide. So when we look at those organizational priorities, what we have is the capital position analysis. On the left-hand side of the slide, you see the uses of cash. You can see the examples that I showed on the next slide. And then on the right-hand side of the slide is the sources of cash. And so on the bottom half of the graph, what you then see is cash flow targets and cash flow projections being out of balance. And that lack of equilibrium results in a $15 to $35 million imperative to improve cash flow and attain that equilibrium. So what you see here is basically the strategic imperative of the cost transformation effort. We've received questions in the past where an organization has perhaps concerning financial outcomes, and we say, what is your goal in terms of your strategic cost transformation project? And they say, well, we don't know. We haven't done the opportunity assessment. And what we do is we come back to them and say, we'd really like to think about that differently. You don't really go after an opportunity assessment first. You really lay your foundation in your strategic position that lays the foundation for the strategic cost transformation effort. The second best practice that we'll talk about is the sense of urgency and foundation to address all foundations of the cost structure of the organization. One of the things that we see time and time again is organizations going after the hard bucket of labor, non-labor, shared services, and overhead. And the reason that organizations tend to go after those categories is because it tends to be less rooted in political sensitivities. These areas are very easily measured. They're easily benchmarked. And so we tend to go back to that well. Unfortunately, what we're seeing in the industry these days is there's an end game to that, is that going back to labor and productivity, if not done thoughtfully and focused on process improvement, can have very dire consequences when it comes to patient safety, quality, access, and the patient experience. Vendors, as we'll talk about in a little bit, really have a strong position in leverage to, vendor renegotiation is something that we're all focused on, but that's becoming much more difficult. So really what we would advocate is to really take the full view of the cost structure in mind. And what we mean by that is areas of network optimization to really figure out, do we need to be all things to all people, or do we need to really focus on what we're really great at in centers of excellence, and what are we not so great at, and maybe what should we divest or no longer stop doing? And really then the holy grail of significant transformation comes in that far right bucket of clinical redesign and clinical variation. Healthcare is really thinking about how we can become, more standardized. The orthopedic service line has really had some great thinking around this of, standard order sets and protocols that not only have really financial returns, but have shown to have significant improvements in quality outcomes and length of stay reductions. And so really to think about cost transformation in this big bucket is really kind of what we're thinking of. But they're not all created equal. We have to address these on the next slide in sort of waves where, we have the short-term need, the short-term outcome, but building that culture of continuous improvement in, wave 2s and 3s and ongoing where, pardon me, the ramp-up period for things like business transformation and clinical transformation is much longer. So we have to kind of think about these waves in unequal forms where the ramp-up period for these other waves has a much more longitudinal effort. And so that's kind of the holistic approach that we would suggest you all take. And then lastly, to begin to set the foundation for accountability. This may seem familiar to many of you, where you have the executive steering committee at the top, and you have several subcommittees throughout the system. It's important to populate these teams with interdisciplinary leaders. Not only do we have operations leaders, but we really want to get the best thinking of our physician groups. Case management and nursing is very important. And then something that may not be familiar to you is the results management office function that we would recommend as the best practice. This results management office is much more than a project management function. It includes finance, it includes human resources. Certainly it does include process improvement and project management. And really this serves as the air traffic control. It identifies the sources of truth for measurement and outcomes. It ensures that all of the sub-teams are working efficiently and have all of the resources they need. And they're also the source of truth on measuring success. So, gone are their days of many groups defining what success looks like. Very early on, the results management office defines the pathway and what success looks like and meticulously tracks those outcomes. Happy to answer any questions or talk further about the results management office at a later time. Then is the next best practice of translating opportunities into actionable targets. Here at Kaufman Hall, we do not view the term opportunity and target synonymously. Rather, opportunities are merely quantified areas of focus. Those areas of focus, however, do not have organizational appreciation coupled with them. So really what we would talk about in this best practice is to go out and what we call triangulate opportunities. What we mean by that is that no one singular opportunity assessment should be relied upon, but really look at opportunities in different ways. External benchmarks, internal trending, internal best practice. So when we look at opportunities in 3 or 4 different ways, and all of those different ways kind of point directionally, we can have much greater faith that those are true opportunities. What we would then do is then understand the organizational priorities and to translate them into targets. So what I mean specifically about that is, for example, if we have a population health strategy, we're not going to want to give significant cost transformation targets in areas that we want to grow, such as case management or social work or primary care, that we would want to kind of change our priorities and not give those cost transformation targets to them. One other quick comment before we move on is that we're seeing some novel data points coming into play in the opportunity analysis, and that is related to the cost accounting data. Organizations as of late have really been trying to leverage their cost accounting data in new ways to understand profitability by service line, contribution margins by service line, and a much more kind of patient-centric view of the cost of care and the opportunities related to them. So we can talk more about that later, but leveraging cost accounting data is an emerging best practice. As John mentioned earlier, we are going to send you all an article that was recently published. And this is one example of a multi-hospital system in Southern California and their validated opportunity assessment. You see that they're low, on the low side, they've identified just under 180 million, and on the high side, just under $330 million. But I think most exciting for us was the type of opportunities they chose to go after. And they really chose to view their initiatives as a true transformation. So you can see the systemization of IT and HR, eliminating redundancies, consolidating cardiac surgery programs, quite political, but they chose to go after that, and really focusing on clinical variation in a number of different DRGs. So really, we would invite you to click on the article and do a deep dive on this case study. Perhaps it has one or two learnings that you might apply to your organization. Specifically, translating these opportunities and targets can take on a few different variations. So here are a few options of target setting, some of which we would recommend, others we probably wouldn't. Organizations sometimes choose not to set targets at a very detailed level. They keep it pretty high level with the organization. The problem with that is it's quite hard to hold leaders accountable for results when they aren't specifically tied to a number. We've seen it time and time again, where targets set at the organizational level tend to degrade over time because that level of accountability isn't there. On the other end of the spectrum is the bottom part of the screen, where we have targets for every single department. And while the levels in lines of accountability are quite clear, the problem with that is it can really reinforce some siloed thinking and folks really not collaborating on those targets. So really what the best practice is kind of a meet me in the middle approach, where we set targets at a vice president level, or some of the targets are allocated to VPs, but a portion are working together. We've also seen targets set at a service line level work, where you're really able to look at the continuum of care in cardiac, for example, pre-admission, the inpatient episode, post-discharge, setting on targets like that, it seemed to be successful. So setting targets at kind of that hybrid level is really what we're seeing work these days. Here's an example. This is a masked example. This organization had a strategic goal to translate their strategic target of $30 million into targets. And what they chose to do is a few things here. They set targets at a vice president level. They set them for both labor and non-labor. And they chose to set targets $5 million higher than their strategic goal. So a couple of details here. This particular organization did not have historical success at leveraging non-labor savings. They were able to develop plans in non-labor, but they knew themselves, and they knew that those non-labor plans were not sustainable for whatever reason. So they chose to set 2/3 of their target in labor expense. You can also see on top that they chose to identify $70 million at the system level that was not affiliated with any specific VP. And really what they did is, I'll show this in just a moment, is to focus on $7 million that the executive team would work on together to identify savings. And in just a moment, I'll show how they did that. So that's one example of setting targets. So the previous best practices that we just talked about are really steeped in data and approach. The next three best practices that we'll talk about are really related to skill sets and accountability. This first one is to improve the financial IQ of the organization. One of the things that we're seeing is when organizations are not able to sustain their cost transformation targets, it's not a result of obstinance or unwillingness to change. It's really organizations don't have the right skill sets to maintain that change. We're not talking about skill sets about reading the P&L. We're really talking about skill sets of, be it board members or frontline managers, not really understanding how to run and transform a business. So really what we're after here is to really understand the process of cost management itself and related skills to process improvement. Let's take nursing, for example. I come from the nursing team, and really, throughout the industry, who becomes the manager of nurses? It is typically the best nurse or the best charge nurse is just promoted. And really what we're seeing is the skills to manage a business were never taught to that nurse manager. And so we're really talking about process improvement and business management skills that the organization needs to have to lay that foundation of accountability and understanding. So to improve that cost intelligence is definitely a skill set worth investing in. Here is a specific approach to build that financial IQ. LEAD is the acronym, and this is this can be a 2 to 3 month process in which the organization immerses itself in cost intelligence training. So view these 4 pillars here as a sort of 1 to 2 day, all-day meetings that are split out, and the organization meets once every 2 to 3 weeks. So 1 to 2 all-day meetings, wait 3 weeks, all-day meetings, wait 3 weeks, and so on. And so the organizational leaders come together, and the first session is really an information session. Why are we here? What are we doing? What are the goals? What is the process improvement approach? And then what you see is this first session is not really bringing a lot of data. We found if the data dump occurs at the first session, it can be overwhelming. So really what we're doing is we're understanding the full scope of the situation, we're reviewing the opportunities, and then we're having the participants in the session really identify the data, right? So these sessions are typically attended by managers and up, and they're facilitated by process improvement experts. So then we then begin to take the clay and mold it a little bit. In the educate session, we're beginning to form what the opportunities might be, what the plans could be, and we're then beginning to quantify. So we're really molding that clay. We're identifying who needs to be involved in evaluating the reasonableness of plans. And so while we do a lot of work during these all-day sessions, really the bulk of the work is in between the sessions. So take, for example, the important work that needs to happen between educate and actuate. You really need to winnow down the opportunities. You really need to spend a lot of time quantifying the opportunities and really begin to set that clay and begin to bake it. So the actuate session, we're really developing work plans, we're refining the estimates, and we're really saying, okay, what are those measures of success? Not just financially, mind you, but what do we need to measure from a quality perspective? What do we really need to measure from an access and patient experience perspective? So really what this process does is set the foundation of, it's less about cost reduction or slashing and burning, but really about organizational transformation led by those leaders who do the work to say, how can organizations look differently over time? And then what you see on the right is the deliver, where here are the plans, here are the quantified savings, here's what the organization will look like in the future, and we will then begin the process of implementation. So that's kind of what that lead process looks like at a high level. So then part of the lead process is the planning process, and we wanted to kind of talk to you about what that can look like. On the next slide, you'll see that we really need to measure both that top-down approach with the bottom-up. So for example, there are going to be plans in the top-down approach that can only be top-down, right? Benefits restructuring, management span of control, that you really wouldn't want to engage the organization in developing. But at the same time, the top-down approach is incomplete because the top-down approach is led by leaders who don't know the day-to-day work and how it goes about operating. And one of the things that we see unsuccessful organizations do is to confuse these two, is to have top-down leaders dictating labor productivity improvements, for example. That is actually best done by the workers in the field, mind you, and really ask the frontline folks, how can we transform the business in which improved productivity would be a byproduct of that transformation, rather than focusing on productivity for productivity's sake. Physician operations is another good example where we really want to engage the clinical leaders on understanding unwarranted variation. Okay, so now let's go back to the targets I talked about a few minutes ago and how that organization translated those targets into savings. So as you remember, those two top rows added up to $7 million. And here is how that organization chose to go after that $7 million. You can see about a quarter of that is in divestiture of real estate holdings. This organization was a very large real estate holder in their community, and they were not all related to healthcare services. So they divested a bunch of those. A benefit comp restructuring, but you see here that they also went after director and manager span of control, and you can see you can toggle through and see what they did here. But then there's the bottom-up approach on the next slide, and you can see that this organization actually spent about 6 weeks developing their $20 million savings. You can see a plurality of that was in the supply chain. But then I want to share with you all of these smaller pies, because kind of looking at them individually really doesn't give this organization the full credit. What they chose to do is really say, what process improvement techniques, Six Sigma, DMAIC, but also Lean, can we bring to the clinical operation to figure out how we can really transform the services we deliver. And they were able to take that 6-week timeline and really identify some significant savings in that type of transformative work. So this is an organization to this day have maintained their savings, and were actually recently upgraded by the financial institutions. It's really a great story here. Okay, as I promised very early on, these best practices are not all created equal. And really what we're seeing is the accountability disproportionately impacting organizations that are successful versus those that are not. It may seem straightforward, but we're seeing quite a bit of variability in organizational culture these days. So let me say a few words about that. Barely a week goes by that we're not asked, what defines success? When you look back and you see organizations that were not so successful in that versus those that are do, what is the secret sauce? And we have good news and bad news on that, right? What we're seeing is that it's not smarter people at certain organizations. It's not more innovative approaches or tools that some organizations have that others don't. It is the hard work of being stubborn. It is the hard work of getting up every day and focusing on this, not from a project perspective, but a day-to-day working perspective. And then it is holding yourself accountable, first and foremost, to performance, and holding your team accountable. And that accountability must flow downward, which is typical. It must flow upward, which is hard. But the hardest level of accountability is peer-to-peer accountability, horizontal accountability, and really having a professional conversation around meeting expectations. And that is what defines success when we're talking about organizational transformation. So you can see some specifics on the screen that I won't get into, but it is that culture of accountability that helps organizations transform themselves. This is the structure I kind of alluded to it at a high level a few minutes ago, but this is really the type of accountability that we're talking about. One of the things that we have to really be careful about when it comes to accountability is the executive steering committee should be the accountability arm. One of the things that we're seeing sometimes is that the results management office, because they have the data, because they have the analytics, and they have the process improvement resources, are sometimes the de facto accountability arm, but we really want to set some clear boundaries there. Is that the ultimate accountability lies with the senior executive team and not with the results management office. So just a note there. And then lastly, we have to have data and information to hold leaders accountable to. Okay, so let me say a few words about that. Once we know that we have the right skills, right, we've built the financial IQ, we've built structures and processes to hold leaders accountable, we then need to hold them accountable to data, to outcomes. And so really what we advocate in that is the plans for transformation must be very detailed. I'm not going to read the ins and outs of this slide, but really what we're talking about here is plans at a job code level, at a wage rate level, at a department level. Once that's clear, that can be loaded into a budget, and then it makes it quite easy. Is managing to a flex budget is really the source of truth and the data needed to hold leadership accountable to outcomes and performance. And so I know there's a lot of data on here, but that's really what we're talking about in terms of accountability to outcomes. So I said a lot over the past several minutes, and I hope what you take away here is a full view of organizational transformation. You know, we talked about cost transformation, but really this is in the context of the strategic plan, the long-range financial plan, and we all know that strategic plan appreciates the full mission, right? Access, quality, the patient experience, and so on and so on. And it is our experience that if we do the full view of everything that's at stake here, that the odds of success are much greater. So I wanted to thank you very much for your time joining us over the phone today, and see if there's any questions or comments.
Yep. Thank you for the very insightful presentation, Kris. We do have some questions that we can get into now, so I want to go ahead and jump into those. First one we have is wanting to see if you can elaborate on how you've seen organizations evolve their approach to cost transformation over the last few years. How have things changed in the industry?
Yeah. So cost transformation isn't new. This has been going on for decades. But one of the things that we've seen accelerating, I would say, especially over the past 3 to 4 years, is the level of complexity. Is that organizations are beginning to address those more nuanced, politically sensitive issues, because what they've learned is they can't go back to the same old well any longer. And so while that's good news, the level of complexity, required infrastructure, the data is becoming more complex, that is needed, is really what we're seeing really take off. We're also seeing organizations build transformation departments that really houses a lot of that intellectual property and has an understanding of that complexity. So I'd say that's the biggest one.
Great, thank you. Another question we have asks, how do we address vendor-related supply chain issues when it comes to areas like pharmaceuticals with limited free market choice?
Yeah, so that's becoming more difficult because as organizations become more savvy and educated and business focused, so are the vendors. And so we really see two options to do that. One is an us versus them mentality. We're seeing some organizations take a hardline approach to say, you know, we're going to write a letter and say we're going to pay XYZ price for these products, and it's a 5% improvement or reduction in what we've paid you historically. only to have the vendor counteract and say, no, not only are we not doing that, but we're going to raise our prices 5%. And we're seeing the supply chain negotiations sometimes get very contentious, and it is really adversarial at times and frustrating for both parties. One of the things we're seeing beginning to work is having a partnership approach to vendor negotiations, to say, what is in our mutual interest. So I have an example for that where, an organization was thinking about purchasing new beds. And really what they did is they brought a vendor in to say, what does success look like for both of us? What are those great stories that you want to tell, vendor, 3 or 4 years from now? And what do we want to tell? And so rather to have an us versus them vendor relationship, they chose to approach it from a strategic relationship. And we're seeing those types of relationships work from time to time, but not always.
Very good. We have another question referencing back to your comments earlier about span of control and asking if there are new benchmarks for that you can comment on.
Yeah. So many of you may know that the quintessential span of control benchmark study was done in 2011. That is actually the most contemporary and reliable data. So a few words on that. There are some new benchmarks out of the operational databases, but they're limited and not necessarily completely actionable. But what we do know from 2011 to today is that span of controls are getting bigger or more aggressive, if you will. So what we would say about those 2011 benchmarks is they're likely to be conservative in today's world.
All right. Thank you, Kris. We have time, I think, for one more question. So I want to ask, what strategies can you recommend? Can you elaborate on strategies for avoiding unintended consequences like negative impacts to quality or access?
We've seen cost transformation work the wrong way. There's a wrong way to do this type of work. I alluded to it before, not appreciating the full mission, purely top-down approach. So really what we wanted to do is first build that balanced scorecard that not only have financial metrics, but has others, as I've already talked about. So that's one. Two is to involve the clinical team, whether that is physicians, NPs, PAs, nurses, social work. It's their life mission to provide strong quality care. And if engaged in the right way, you'll be encouraged by their level of participation and engagement for cost transformation as well. So that's the second one. The third is constant monitoring. We have to develop measures of success, certainly that are financial in nature, but we are always on the lookout for those leading indicators that say, well, something might not be looking right in terms of the patient experience or length of stay. So let me actually touch on length of stay as a specific example. We're actually seeing that length of stay might be a leading indicator on this, that we might see cost improvements occur. The quality scorecard seems to be okay, but if you begin to see erosion or degradation in length of stay, that may foreshadow impacts to quality and patient experience. So really begin to scrutinize your length of stay when talking about cost transformation, because that could be a leading indicator of potential downstream consequences.
Excellent. Thank you again for sharing your insights with us here today, Kris. You can see Kris's full bio here on the screen, and as well as his contact information, his email address and phone number, and welcomes you reaching out to him with additional questions today as you further contemplate how to best approach cost transformation in your organizations and how to make sustainable improvements. Welcome your further questions and reaching out to Kris with your ideas and thoughts. And thank you again for your participation and wish you all well moving forward.
Thank you.